Okay, so you may or may not have seen this publication, a series of publications in Epilepsy last year on the classification of epilepsy syndromes. I've been interested in epilepsy syndromes for a while, as you'll see. So, that's so long ago, I don't even remember when it was. It was a long time ago. And I thought it was all fine then. Well, apparently it wasn't, and it needed changing, so it's been changed. So there've been a series of publications from the ILAE position statements in the last few years on seizure classification, syndrome classification, and the 2022 ones on syndrome definitions. That's the first two on seizure classification, and then this one, and then this series more recently. I complained a lot about the classification, the seizure classification one, and so they put me on their committee so that I would not be able to complain so much, and I was involved in the syndrome classification ones as well. So this is from one of the 2017 papers, and it's important because it shows the relationship between seizure types, epilepsy types, and epilepsy syndrome. So if we start with the seizure type, it can be focal or generalized. One of the things I disagreed with was the idea that you can have a seizure that's of unknown type. I mean, you might not know that it's a seizure, but there's no specific seizure type called an unknown seizure. It's not a biological thing. Anyway, I lost that argument too. And then that determines the epilepsy type, which can be focal or generalized, or if there are both focal and generalized seizures, then we call it this combined generalized and focal. And then if we have some more information, we can diagnose an epilepsy syndrome. So what is an epilepsy syndrome? So the same seizure type can occur in different diseases. For example, myoclonic seizures can occur in juvenile myoclonic epilepsy, but the same seizure can occur in someone with progressive myoclonic epilepsy. And those are very different diseases, but the seizure may be the same. So syndromes are defined by more than just seizure type. The definition the ILAE uses is a characteristic cluster of clinical and EEG features often supported by specific etiological findings, structural, genetic, metabolic, immune, and infectious. Does it matter? Is this necessary? Well, it helps a lot. Focal syndrome implies a focal lesion. You may not be able to find it, but it implies that there is a focal lesion there. Generalized onset seizures or generalized syndromes imply that there is no structural lesion in the brain. That's very important, obviously, for investigation and management. It may also help with prognosis. For example, idiopathic generalized epilepsies generally are pretty easy to treat, whereas focal epilepsy is responsive to therapy much less often. And developmental and epileptic encephalopathies generally respond poorly to treatment. And there are some specific syndromes that allow us to predict whether the epilepsy will be responsive to specific drugs, whether it's likely to resolve with time, and what the developmental outcome is likely to be. And of course, for research, different research groups have to be able to communicate and know that they're working on the same condition. So if we go back to this slide here, we can see that the first step is to diagnose the seizure type. And in 2017, there was a new classification of seizure types. And it had these two broad divisions of focal onset and generalized onset. And focal onset was defined as originating within networks limited to one hemisphere, generalized onset originating in some point within and rapidly engaging bilaterally distributed networks. One of the complaints I had is I don't think that definition is really very accurate. And in practice, focal onset means that the seizure looks like it starts in one hemisphere. It appears to start in one hemisphere. Generalized onset, the seizure appears to start in both hemispheres at the same time. An important point is that when we talk about focal seizures and generalized seizures, we're talking about the onset of the seizure. So a focal seizure, the seizure begins in one hemisphere. What happens after that doesn't matter. It may go to the other hemisphere, but it's where it starts is the important thing. The term awareness, now you'll see that focal onset seizures are divided into focal aware and focal impaired awareness seizures, or seizures with impaired awareness. Awareness is a term used to mean consciousness. And consciousness, for this purpose, is defined as awareness and responsiveness and memory. And impairment of any one of those three things is enough to say this is an impaired awareness seizure. And then we've got focal to bilateral tonic-clonic seizures, and then in the generalized group, motor and non-motor, and these ones motor and non-motor as well. The old terms have been replaced, so partial becomes focal, simple partial becomes focal aware, complex partial becomes focal impaired awareness. And focal, secondarily generalized seizures down here become focal to bilateral tonic-clonic seizures. And then we can become more detailed depending on what the clinical features of the seizure are. And this one here is it's the predominant manifestation of the seizure is what gives it the name. And what's new in this, or was new, is that you'll see that there are some seizure types that are in both focal and generalized. For example, clonic and tonic can be generalized or focal. Myoclonic can be focal or generalized. Infantile spasms or spasms can also be focal or generalized. So these 4 papers defining the syndromes I'll talk about now. This were the 2022 papers. And one point that I think I should tell you is that although these papers were divided, the syndromes were grouped according to age of onset, these 3 papers, that's not part of the classification. So these papers were not really a classification of seizure syndromes. They were a definition of seizure syndromes. They were, this is what you need to have this syndrome. The classification of seizures, in other words, which ones go with which other ones, that wasn't covered here. That was covered broadly in that 2017 paper. Idiopathic generalized epilepsies is a classification, and that was a separate paper. I'll talk about that in a minute. So how are these individual syndromes defined? Well, as we've said, seizure type determines epilepsy type. So if you have focal seizures, then your epilepsy syndrome is a focal epilepsy syndrome. But then if you want to be more specific, you need other information like age of onset, development at onset, neurological examination, EEG, neuroimaging, and sometimes other studies like genetics or sometimes biochemical studies, and whether there are comorbidities as well. So here's an example from one of those papers. This is childhood absence epilepsy, and there are 3 or 4 columns. The first one saying what we're talking about. The next one is what you must have. So you must have to have childhood absence epilepsy. You must have typical absence seizures. You must have an EEG showing 2.5 to 4 Hertz generalized spike wave activity. And that's it, really. Exclusionary column here means that if you've got any of these, then you do not have childhood absence epilepsy. So if you have, for example, tonic seizures, then you don't have CAE. If you're too young or too old, if you have intellectual disability, then you don't have that diagnosis. Now, there's this big column in the middle called alerts. And I'll tell you why that's there in a minute. But basically what it means is if you have one of the things in this alerts column, then it means that this is unusual for this syndrome. So it doesn't mean that it's not the syndrome, but it means it's probably not the syndrome, and so you need to look again and be sure that it really is. And then we've also got a couple of other further things, neurological examination, comorbidities, and so on. And there's, I don't know if you can read this down the bottom here, is syndrome without laboratory confirmation. And the idea of that was to cater for countries where the investigations were not available. So, for example, in Timor-Leste, a child who you think has absence epilepsy cannot have an EEG. So if EEG was a mandatory requirement, then you couldn't diagnose childhood epilepsy on a child in East Timor, and that clearly doesn't make sense. So they went through went through all of their syndromes, and some syndromes they felt you just had to have a test to be able to diagnose the syndrome, but with many of the others, you could still make a diagnosis clinically. It would be good to have an EEG and an MRI and genetics and so on, but if they're not there, that doesn't mean it's impossible to make the syndrome diagnosis. This is just a list of the syndromes showing the age of onset. These are the focal ones, the generalized ones, and combined generalized and focal. And here's some more. These ones are ones with developmental encephalopathy and progressive neurological deterioration, which I'll mention in a minute. So I want to just mention briefly IGE, idiopathic generalized epilepsy, and GGE, genetic generalized epilepsy. So a few years ago, the ILAE said, we don't want to call things IGE anymore. We'll just put them in this big category called genetic generalized epilepsy, because they don't really, there's no reason to have their own group. Neurologists became very upset about that, because most clinical neurologists find the concept of IGE very useful. And so the ILE had to go backwards and say, okay, you can have IGE, but only for 4 syndromes. And those 4 syndromes are childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone. So idiopathic generalized epilepsies is part of a bigger group called genetic generalized epilepsies. And that big group includes, as well as IGE, includes things like What have we got? Myoclonic epilepsy of infancy, epilepsy with myoclonic absences, and so on. Now, these things are much less common. The vast majority of genetic generalized epilepsy is made up of these 4 syndromes. They're really common. And the ILAE now realizes that it is a good idea to put them in the same group. And the reasons are they have features in common. They share features. Including age of onset before age 20. Epilepsy is the only neurological disorder. They're neurologically normal apart from having epilepsy. Have a family history commonly. The EEG shows a normal background and shows generalized spike wave activity, sometimes with photosensitivity. And they usually respond pretty well to treatment, especially with valproate. And some drugs will make them worse, may make them worse, such as carbamazepine. And the seizure types are generalized onset seizures, absence, myoclonic, tonic-clonic, and they're common. So those are the reasons for grouping them together. The other thing I thought I'd mention is this concept of the developmental and epileptic encephalopathy, because I personally find this pretty confusing and not a very useful. Anyway, I'll tell you what the idea is. The idea is that in some children with intellectual disability, their intellectual disability is caused by the same thing that caused their epilepsy. So, for example, hypoxia, ischemia when they're born. So that causes their developmental disability and also causes their epilepsy. Now, the idea is that in some children, the epilepsy itself causes some intellectual disability. And perhaps in some children, if you could treat their epilepsy successfully, they would not have intellectual disability. So we would call the first one where there is, or the first situation is where there is something happens to the brain like hypoxic ischemic encephalopathy at birth. The child has epilepsy, but the epilepsy is not actually making any difference to that child's disability, intellectual disability. That would be called a developmental encephalopathy with epilepsy. If they have disability which is caused only by seizures or possibly by interictal activity in the brain related to their epilepsy, then we call that epileptic encephalopathy. Now, there's also a big group where they may have both. The problem is you usually can't tell. The idea is to try and treat the seizures as best you can and hope that that is going to improve the cognitive function by treating the epileptic component of their encephalopathy. So I don't know if you find that confusing, but I do. And I think part of the problem is the term. I think it should be called epilepsy with epileptic encephalopathy, or epilepsy with developmental encephalopathy. It's encephalopathy and an epilepsy syndrome are not the same thing. So it shouldn't be on a list of syndromes. But anyway, I lost that argument as well. So just to talk about practical challenges in defining syndromes. The first is that you want to be consistent and you want to be logical. But the problem is you also want this system to be clinically useful to doctors treating patients. And you also need to take account of existing conventions. So like that term IgE, for example, was very widely used, very well accepted, very useful. You need to, just trying to get rid of that is going to cause problems. So there is a tension between consistency and logic on one side and maybe new research compared to clinical usefulness and existing conventions. There isn't a perfect solution to that. So the one is the more sort of academic approach and the other is the more clinical approach. And when they come together, there can be problems. I've already mentioned access to investigations in some countries. And how do you handle outliers? So if you look at the literature, there are people with juvenile myoclonic epilepsy with their first seizure at the age of, I don't know, 45 years old. So should we say the age range for juvenile myoclonic epilepsy is up to 45 years old? Well, if we do that, if we try and cover all possibilities, then we will broaden the definition and it becomes less specific and therefore less useful and maybe misleading. So the way to handle that is with those alerts. So in the alert column, it says, if your patient with juvenile myoclonic epilepsy is aged 45, then it's probably not juvenile myoclonic epilepsy, and you need to have another look. So I think that's quite a useful thing. There is conflicting evidence and opinions amongst experts, and certainly there's a lot of disagreement in some of these task forces in the ILAE. There are, and the way to try and resolve those is to discuss them amongst themselves and try and come to an agreement, but that's not always possible. And then it comes down to personalities, who's the most dominant personality, and there may be some politics involved and so forth. So it's a very challenging thing. And then lastly, which syndromes to include. So if there's some syndrome that's been described that's, affected 20 people and is associated with some specific genetic mutation, should we put that in and call it an epilepsy syndrome? I don't think there's an easy answer to that. On this committee, I wanted autoimmune epilepsy, some autoimmune epilepsy syndromes to be included, like faciobrachial dystonic seizures with LGI1 antibodies. And that was rejected because the autoimmune group in the ILAE had already produced a paper and said these are acute symptomatic seizures. It's not an epilepsy syndrome. So that was the end of that. How to diagnose a syndrome? So the most important first step are the seizures focal or generalized? Okay. So how do we do that? Well, there are some clinical pointers that I think are useful. If the seizure has focal or asymmetric features, it's more likely to be focal. If there's an aura, it's more likely to be focal. If there are neurological abnormalities by history or examination, if the patient's over 20 years when they have their first seizure, if the seizures occur from deep sleep, it's more likely to be a focal onset. It doesn't have to be, but it's more likely to be. On the other hand, if the seizures occur almost always just after waking up in the morning, if there's myoclonus, if the seizures occur infrequently, maybe 1 or 2 a year, and if all of the seizures are tonic-clonic seizures, then it's more likely to be generalized seizures. So how to diagnose it? A syndrome, we need detailed history from the patient and witnesses. We need a neurological examination. If you can do it immediately after a seizure, you may find signs, focal signs that aren't there at other times. EEG, imaging, everybody these days has a camera in their phone, and that can be really useful in figuring out what kind of seizure the person's having. And if it's available and if necessary, and only if necessary, not every patient needs it, then you can do video EEG. So in conclusion, classification is clinically useful. It's essential for research. Devising a system of classification is very challenging. The ILAE seizure and syndrome classifications are not perfect, but I think they are a good effort and people have really tried hard. And clinical diagnosis, though, remains extremely important. Thank you.